It's my pleasure and also my privilege to talk about a study that Professor Ronco, along with his fellows at the International Renal Research Institute of Vicenza, conducted. And that is actually what should be on my disclosure slide, that I'm biased because I was one of those fellows. So, like Professor Katz already said, I'm going to talk about renal function reserve and kidney stress biomarkers. And to begin with, I would like to talk a little bit about the Qadir Guidelines, which I normally like to talk about when I talk about AKI. So we all know that the Qadir Guidelines say we have to identify and recognize the highest acceptable patient, which is, like we all know, pretty difficult because especially in patients who don't have underlying chronic kidney disease. In fact, one of the main determinants for the individual's acceptability is, on the one hand, the comorbidities that the patient has, like hypertension and diabetes, and on the other hand, the number of intact nephrons, which essentially relate to the functional capacity of the kidney. However, as you can see here, up to the time of birth, the number of nephrons can vary significantly, which is nowadays seen to be one of the main reasons why some patients are more prone or more susceptible to develop chronic kidney disease, and that is a low nephron endowment at birth. And you also see that there is a physiological loss of nephrons occurring with normal aging. So there is a dynamic within the kidney that we may or may not always take into account. And to get an idea of that, some colleagues of the Mayo Clinic looked at living kidney donors who had a pre-donation CT scan and a protocol biopsy of the donated kidney during transplant surgery. And in those biopsies, they analyzed thoroughly how many glomeruli are intact and how many are sclerotic. And with that information, the density of the glomeruli and the cortical volume measured in the CT scan, they estimated the total number of nephrons throughout the age. And what you can see here is that the number of intact nephrons decreases with age, that would be the white bar, and at the same time, the number of sclerotic glomeruli tends to increase. But what I want to show you is when we add both the number of sclerotic and intact glomeruli, there is a gap, right? So the sclerotic glomeruli, they don't fill the gap, and that can only mean that there is a subsequent loss of nephrons. And when we look at it in terms of quantity, then we realize that at the age of 70, 75, almost half of the intact nephrons are lost. And those are the candidates that are, well, accepted as living kidney donors. But the reason why I want to show you this is another aspect. You see that the GFR decreases almost linear with age, so that's nothing special. But after the age of 60, the GFR decreases to a lower extent than the number of intact nephrons, which can only mean that the individual glomeruli, they have to work more. Hyperfiltration and compensation. And that leads us to the concept of renal function reserve. So measuring GFR is good, counting glomeruli is better, no doubt, but it is a little bit extensive. So the question is there anything else? Can we get more information out of it? And one of these information may be the glomerular reserve. Are the glomeruli in a particular situation at the limit, or are they still capable to increase the GFR? So one can form the hypothesis that glomeruli working at the limit, they have a worse prognosis for AKI or development of chronic kidney disease from those who still have the capacity to regulate the GFR up and down. So the assessment of renal function reserve, which is the capacity of the kidney to increase the GFR, might help us here, right, to discriminate between patients who are at risk for AKI from those with better preserved renal function and a more favorable prognosis. And, well, only after the renal reserve is lost, creatinine will theoretically increase and diagnose according to KDIGO, and before that, all insults may stay subclinical, leading to a significant damage of nephrons, however, not affecting baseline GFR. So to prove that subclinical AKI has a meaning, it was recently shown, and that slide was actually shown multiple times during the last days, that patients displaying a positivity to biomarkers, however, not having a creatinine rising, they seem to have a similar worse outcome compared to patients who have a clinical AKI and a rising creatinine. So it may make sense to combine new AKI biomarkers together with already existing markers of AKI to better characterize the patient. So when the cardiologists do the stress ECG, the nephrologist could do the stress GFR, right? How can we do this? It's not that difficult. We can do it with protein loading. And can we standardize it? Yes, we can. So this is a small study, but a well-conducted study in 18 probants who had cooked meat of 1 gram per kg body weight, 2 gram per kg body weight, and 1 gram per kg protein powder, so some type of dose-response testing. And what you can see is that the GFR that was measured as a creatinine clearance increased from baseline 100 to stress values around 140, which is actually substantial. And the difference between the small stake and the very small stake wasn't that much, meaning that this is probably the plateau that we will reach with protein loading. So to test our hypothesis that renal function reserve has a prognostic and diagnostic value, we conducted a prospective study in patients undergoing elective cardiac surgery in Vicenza who had a normal renal function, at least a GFR more than 60, and all those patients had a renal function reserve test 1 day before cardiac surgery. And the reason why we chose cardiac surgery is pretty simple, because AKI is typical here, and we know the timing of injury, which is the surgery. And immediately after surgery, we analyzed creatinine, urine output, and AKI biomarkers to analyze how many patients develop AKI according to KDIGO and how many patients develop subclinical AKI according to biomarkers. And to go one step further, we did a 3-month follow-up, and at this 3 months, we redid the renal function reserve test by protein loading to analyze how much is left of the whole functioning renal mass. So as biomarkers, we chose TIM2-IGPP7. Since those are currently one of the most promising biomarkers, they seem to be more sensitive to injury than serum creatinine, and because thresholds have been proposed for the clinical use. So we defined subclinical AKI as biomarker levels above 0.3 without positive KDIGO criteria. And with that study, we tried to clarify a little bit what is the nature of an AKI event, both subclinical but also clinical, but also the events following after any type of AKI, including repair or maladaptive repair. And studying renal function reserve at 3 months would allow us to analyze how many patients have some loss of renal function, which is, however, clinically not evident or subclinical, because part of the nephrons have been lost, but still baseline GFR is the same. So now to the results. According to the inclusion criteria, baseline GFR and estimated GFR was normal in all the patients, with mean values of 103 and 91 ml per minute. The preoperative renal function reserve was a median 25 ml per minute, and the urine albumin to creatinine ratio was 6.5 milligram per gram creatinine. So now to the AKI rates and test performance. Of the 110 patients, total 15 patients developed AKI, and among those, 10 had stage 1 AKI and 5 had severe AKI, which we defined as stage 2 and stage 3. all patients were diagnosed within 48 hours after surgery and staged according to positive serum creatinine criteria, and none of the patients had positive renal output criteria. So, regarding the preoperative renal function reserve, it was significantly lower in those patients who subsequently developed AKI with median values of 15.5 ml per minute, while patients who did not develop AKI, the median values were 27 ml per minute. So when we went one step further and looked at the preoperative renal function reserve in terms of interval and the risk to develop AKI, we saw a clear trend, meaning that the higher the renal function reserve, the less it is likely that the patient will develop AKI. And we estimated that the preoperative renal function reserve predicted patients who would subsequently develop postoperative AKI with an area in the curve of 0.83, and we estimated actually that a cutoff value of 15 ml per minute had a good sensitivity but also an excellent specificity. In fact, patients with values less than 15 ml per minute, they were 11.8 times more likely to develop any type of AKI. By contrast, traditional preoperative AKI risk assessment using renal function measures like estimated GFR, urine albumin to creatinine ratio, demographics, and comorbidities, they fail to discriminate risk. Also, preoperative biomarkers like kidney stress biomarkers and urine albumin to creatinine ratio, they did not show a good discrimination for AKI prior to surgery. However, among postoperative biomarkers, TIM2, IGF-BP7 identified AKI with an area in the curve of 0.87. And interestingly, almost half of the patients had subclinical AKI, means KDIGO negative, but biomarkers positive. So now to the next point, renal recovery. At hospital discharge, all patients had normal renal function, including the 15 patients who showed a full clinical recovery when it comes to serum creatinine. And that was the same what we saw at 3 months. However, total 3 patients developed a de novo chronic kidney disease, and among those, 2 had AKI and 1 had a subclinical AKI. So now to the last point, 3 months renal function reserve. So from the patients, total 86 patients were available for the complete follow-up, including protein loading, and of the 15 patients who did develop AKI, total 10 patients completed the follow-up, while the 1 patient who died was among the AKI group. So at 3 months, among AKI patients, the loss of renal function reserve was 4.7 ml per minute. That's a loss of 30% compared to preoperative values. While patients who did not develop AKI, they did statistically not have a significant loss of renal function reserve. So when we went one step further and sub-staged the patient, the AKI patient, we saw actually that patients with stage 1 AKI, they had a loss of 3.7 ml per minute. That would be a loss of almost 25% compared to preoperative values. And that patient with severe AKI, they even had a loss more than 15 ml per minute. And that would be a loss of almost all of the reserves, preoperative reserves they had. And when we further subdivided the AKI negative patients who had increased biomarker levels, we saw that even patients who had subclinical AKI, they had a loss of 6.4 ml per minute, and that's a loss of more than 25% of the renal reserve that the patient had before the surgery. So that would be a loss comparable to patients who had a stage 1 AKI. So to sum that up, in patients undergoing elective cardiac surgery with normal renal function, we saw that the preoperative renal function reserve was highly predictive for postoperative AKI. And importantly, patients with values less than 15, they were 11.8 times more likely to develop any type of AKI. And however, preoperative AKI risk assessment using traditional factors like renal function, creatinine, demographics, and comorbidities, they failed to discriminate risk. And second, at hospital discharge, all AKI patients had clinical recovery in terms of serum creatinine. And at 3 months, only 3 patients developed de novo chronic kidney disease. However, none of the AKI patients, they had renal function reserve values equal to preoperative values, and AKI was associated with a significant long-term loss of renal function. And this loss was around 30% compared to preoperative values. Third, we identified a high percentage of patients who had subclinical AKI. And among those, at 3 months, only 1 patient had renal reserve values comparable to preoperative values, and only 1 patient developed de novo chronic kidney disease. However, subclinical AKI, even if the patient did not have the criteria of KDIGO, they had a significant loss of renal function reserve at 3 months, and that loss was around 25% compared to preoperative values. So I believe that our findings has important implications for clinical practice. So although this is a small study, it suggests that at least the renal function reserve has a role in AKI preoperative risk assessment, right? But also probably in any other clinical scenarios, like before we give any nephrotoxic drugs or anything else, as it might help us to identify the highest acceptable patient who is likely to develop AKI, but it also actually characterizes this patient as already having a condition of preclinical chronic kidney disease. And at the same time, renal function reserve may have a role to assess long-term renal outcome after any type of AKI, as it might distinguish between patients who have a full recovery that would be a normal baseline GFR and the renal function reserve is normal, but also the patient could have an apparently full recovery, which means they have a normal baseline GFR, but the renal function reserve is reduced. And it could also be that the patient do not show any recovery after any AKI. That means they have a loss of renal function reserve, but also a reduced baseline GFR. So this study has limitations, like the relatively low AKI rate, which is, well, actually not surprising because we excluded the most important risk factor for AKI, and that is chronic kidney disease. Also, we chose patients who had a low comorbidity status, who underwent elective cardiac surgery, and many of them had minimal invasive surgery, all factors which are actually associated with low risk of AKI. So to sum that up and to wrap it all together, I would like to emphasize that this is probably the first study that shows that renal function reserve as a preclinical tool might enable us to identify patients who are at risk to develop AKI and also characterize these patients that they might already have a preclinical chronic kidney disease despite they have a normal renal function. And with that, I would like to thank you.